Hello again. Now, one of the most important events taking place at this year's EASD Congress is the ADA EASD consensus on the management of type 1 diabetes. And to talk to me about that and tell us what it contains is Richard Holt. Hello.
Hello, Vivienne. Lovely to be with you.
So tell me, first of all, we've obviously had the type 2 consensus statement before. What is the background to this one?
As you say, the influence of the EASD ADA type 2 diabetes report has been highly influential over the last couple of years. And I think that both the EASD and ADA recognised the need to have a similar report that was devoted towards the management of type 1 diabetes. But beyond that, I think it's also important to recognise that in recent years, there's been a huge development in terms of the management of type 1 diabetes, both in terms of the insulins that we have, the way that we deliver those insulins, plus together with all of the new ability that we have to monitor blood glucose. And alongside those advances, there's also been a recognition of the burden of living with type 1 diabetes and the psychosocial consequences of living with type 1 diabetes. So the writing group was very much aware that there is a large amount of national and international guidance that's been written about type 1 diabetes, but it's not necessarily always in one place. And part of the purpose of the report was to try to bring together the best evidence and the best guidance into one consensus report that would actually be a useful tool for healthcare professionals caring for people with type 1 diabetes, really to provide the latest and the best evidence to support their clinical practice and really to help them support people living with type 1 diabetes.
And what are the key features? Can you take us through them?
So the report is actually divided into 17 sections, and I won't go through all of those in the interest of time now. But I think that probably the highlights that really come out of the report is first an algorithm for the diagnosis of type 1 diabetes. It's clearly recognized that there are a number of people who will develop type 1 diabetes in adulthood, and they can span the whole of the lifespan. But what we also know is that people over the age of 40 are often misdiagnosed when they have type 1 diabetes. And something like 40% of people with type 1 diabetes diagnosed in older adulthood will actually have a diagnosis of type 2 diabetes before the final diagnosis is made. So we have a straightforward clinical algorithm that should help guide clinicians through that process to make sure that people have the diagnosis made as early as possible. I think one of the other key messages that comes out of the report is the way that we should be monitoring blood glucose. The report is very clear that the use of continuous glucose monitoring has really transformed the management of type 1 diabetes. And this should be seen as the standard of care for most people, most adults living with type 1 diabetes. We've also included within the report an understanding of that psychosocial burden of living with diabetes. And across each of the management sections, we've tried to embed the importance of psychosocial care within those management sections, particularly around individualizing care and really taking a patient-centered approach when we start to think about making those discussions about the management of type 1 diabetes. And beyond those sections, sorry, go on, Vivienne.
I was going to say, how often is this going to be updated? Because as you're talking, I'm thinking that the care, particularly the technology of devices, is moving ahead so quickly. Is there a danger that this consensus statement is going to, or consensus report rather, is going to be outdated very quickly?
Well, I mean, of course, that is always a danger. This was the first iteration of the management of type 1 diabetes consensus reports. And in the same way that the EASD and ADA have updated the type 2 diabetes consensus report, I'd certainly hope that, that this report is also updated as well. Within the report, we've been quite careful to try to future-proof the report as far as possible by signposting people to other documents where there is greater detail. And of course, some of those will be living documents that will be updated perhaps more frequently than the consensus report itself. But nevertheless, there will be the links to those that will enable the report to remain current even beyond the end of the EASD.
What about type 1 diabetes care in special situations? For instance, I know that pregnancy is a particular interest of yours. What does it have to say there?
So within the report, we've also highlighted some of the areas where there is a need for diabetes care in special populations, and you're absolutely right. We have included a section on pregnancy, but again, actually signposting people out to other more detailed documents, because of course there is a limitation to what we can include within the report. In addition to that, we have a section on caring for older people with type 1 diabetes. We've also got a section on people who've got advanced complications of diabetes, and also the very important situation where people are admitted to hospital with type 1 diabetes, even if the diabetes isn't the major reason for those individuals being admitted to hospital.
Yes, that's often a gap in care, isn't it? When people go in for something else and people say, take them off their medications, and somehow people are left without their insulin, which is a disaster.
Yes, and I think we've been quite careful to actually try to empower people with type 1 diabetes so that if they are in the hospital, that they are able to continue to monitor and manage their diabetes where it's clinically safe for them to do so. And similarly, in the section on older people, we've also highlighted the need to individualize care, and that this should be done based on biological age rather than chronological age, so that older people are not disadvantaged just because of their advancing years.
And we do tend to infantilize people. And of course, people living with diabetes, particularly type 1, they are the masters and mistresses of their own condition. They know it better than anyone else.
Well, they've had that opportunity to be living with it for many, many years, because, of course, type 1 diabetes is more frequently diagnosed in younger life, and they may well have been living with it for decades by the time they admitted into hospital at a later stage. And often they know far more about their own diabetes than the healthcare professionals that are looking after them within an inpatient setting. So I think that there is that importance to make sure that people are able to stay in control of their own management rather than having taken that away from them.
One of the particularly important aspects of these consensus reports is their value to policymakers, because it's very difficult for people to make a case to governments, to healthcare systems, without having this kind of report to back them up. And do you see that as being a particular value to this report?
Oh, absolutely. And we've been very careful in the way that we've tried to write this so that policymakers can't use this as an excuse for denying people care. We've also been very careful to highlight some of the social determinants of the outcomes of diabetes. We've talked very much about the needs where best possible care, but also we have discussed some of the situations and what people might do where people are less advantaged, and how to ensure that they also get the best possible care, despite the fact that they might not necessarily have insurance or full access to care. But we've been quite careful in the way that we've written this to try to make sure that policymakers are very clear about what is the best possible care, and to support healthcare professionals to use the document as an advocate to improve services for people with type 1 diabetes, so that they get the care that they really deserve.
Anything else that you'd particularly like to draw our attention to?
Well, I think that clearly I'm here on behalf of a very large team writing the group. We had 14 people across the team. I had a fantastic co-chair in Dr. Ann Peters from California, but also supported brilliantly by a wonderful team working from both sides of the Atlantic and in different disciplines. And I think that one of the strengths of the report is the way that we've brought our different perspectives from our different health services and our different backgrounds to really bring together the best possible evidence to create the document. I'd also just like to thank actually the people that were involved outside our writing group as well. So we had some excellent reviewers from the EASD and ADA, and also support from the board and Committee for Clinical Affairs. But after the report was presented in draft at the ADA, we also had tremendous interest from people working either individually or in groups in clinical settings, academia, and across industry, and their comments have certainly helped us to shape the report to make it as most relevant and as good as it possibly could be.
One of the things that struck me was the interdisciplinarity of it. In other words, this is not just about diabetologists or endocrinologists, it's about a whole range of other specialties within medicine and outside medicine, and taking account of their views too.
Yes, absolutely. So we were very careful that when we selected the writing group, that we would try to be as diverse as possible, both in terms of geography. So we have representatives across Europe from both Western and Eastern Europe, and also North and South. We also have representation from different genders, but as you rightly said, also differences in terms of discipline. So we've got health psychologists, we've got diabetes educators, as well as people working as doctors as well. So I think that diversity, not only just within Europe, but of course across our American colleagues, has really strengthened the development of the report.
Now, the great phrase of the moment is precision medicine. Is that accounted for in this report?
Well, I think it is to a certain extent. So we're talking about the diagnosis of type 1 diabetes. And of course, that's really important in terms of making an accurate diagnosis as quickly as possible in order to try to pinpoint the right investigations for people according to their presentation, and taking it beyond perhaps what was just written in diabetes textbooks when I first qualified. We've also talked about the needs for individualising care across the report, and that's a theme that goes through many of the sections to try to ensure that the best care is provided to the individual, rather than to think about this as being a one-size-fits-all.
And are we including genomics in this, or is that not yet included in the care of type 1 diabetes, apart from in the initial diagnosis?
So we haven't really fitted in genomics within this particular report, although there is we do discuss the need for genetic testing to exclude maturity onset diabetes of the young as part of the diagnostic algorithm.
Now, if I was just an average diabetologist in an average hospital, anywhere in Europe, what are just the three things that you would really draw to their attention from this report?
Well, I would encourage people to read.
Obviously, they're going to have it as a bedtime reading. They will have it by their bedside, and they'll be reading it. We have written it in a way that we've tried to make sure that it is readable, and it's not too long. It's certainly not a tome, so it is something that people can read. Having proofread it on several occasions, I can tell you it doesn't take that long to go through it. But I think if I was to really pinpoint the absolute highlights of the report, I'd highlight the diagnosis. I'd highlight the monitoring in the way that we describe how continuous glucose monitoring is now really the standard of care for people with type 1 diabetes. We've also talked about the need to use insulin analogs as the primary way of delivering, of using insulin for people with type 1 diabetes. And we've also talked through some of the benefits of using some of the latest technologies, things like pumps, and also the latest hybrid closed loop systems, as well as the
optimal way of actually trying to deliver insulin, but while recognizing that that isn't possible for everybody, and there is a need for individualization and the need to find the right treatment for the individual person.
Now, one of the things, I guess, about these kind of consensus reports is that they sit on a mountain of other practice. And sometimes it's as important to say to people what they should no longer be doing as it is about what they should now be doing. So is there anything that people really should be consigning to the past now?
Well, I think that will probably largely depend on the situation in which people live. So although we are quite clear that continuous glucose monitoring is the standard of care for people with type 1 diabetes, there is still the need for blood glucose monitoring for some individuals where CGM is not possible because of funding. Similarly, if we think about the use of insulins, although we are very clear in our report that insulin analogues are the treatments of choice, we also recognise that those aren't necessarily available for everybody, so that some of the older treatments may need to be used in those situations. So I don't think we've necessarily consigned anything completely to the rubbish bin at this point. But I think that what we have tried to do is to highlight where the newer areas of care have superseded the old ones, although recognizing that even in that situation, some of the older treatments may still be necessary because of the clinical situations that people live in.
Now, I don't know whether it was deliberate or just a happy accident that this consensus report appears in the year that we are celebrating the centenary of the discovery of insulin. But how do you think Banting would view your report?
Well, I would hope that he would see this as being following in a long line of people's efforts to try to improve the care of people living with type 1 diabetes. And clearly we could never have done that without insulin in the first place. So obviously we have a huge debt of gratitude to Banting and Best and MacLeod and Collip in terms of the discovery of insulin. But I would certainly hope that they would see this as being a way of taking forward their discovery to optimize the care of people with diabetes. So I'd hope that wherever they may be looking down on us, that as they read through the report, that they're smiling and thinking that this is a way forward.
And finally, what are you looking forward to in the future? What do you see being included in updates in, say, 5 or 10 years' time, looking at all the things that are going on? I mean, I was thinking particularly of immunotherapy and all those other things that are coming up fast for type 1.
So in the report, we also, our final section is around future and emergent therapies, and we've discussed some of the ways in which we might be able to replace beta cells using either stem cell therapies, and thinking about some of the ways in which we can improve transplantation into the future to make it an opportunity for more people without some of the disadvantages that we currently have with immunosuppression. And we've also got a section on the new immunotherapies and the ways that those might be used to either prevent diabetes altogether, or at least used in its very early stage to slow the progression to a clinical pattern of type 1 diabetes. So lots of really exciting new therapies coming out that I'm sure will be included in future iterations. But perhaps in the nearer future, we may also see even better technologies that we have for both monitoring blood glucose and also delivering blood glucose, to remove some of that burden that people have having to think about the amount of insulin that they need to administer on a daily basis. So even even before we move on to some of those immunotherapies and stem cells, I still think there's going to be a lot of advances over the next few years that will, again, improve the lives of people with type 1 diabetes.
Professor Richard Holt, it's a magnificent document. Congratulations to you and all your writing committee, and thank you so much for being with us.
Well, thank you very much for the invitation, and I hope people will join us on Friday when the report is launched.
And you know what should be on your bedside table from now on.